if he didn't have a complete tear before and then it was a calf strain with a partial rupture, it could confuse the clinical picture, and then later he tore it even though it was only partially torn before. Or he had a complete tear. Could it have been a misdiagnosis? That I'm certainly not going to say that. All right, guys, today we're going to talk about Achilles tendon injuries and how to diagnose them from the ankle standpoint. We have a willing volunteer here, and we're going to go over what's called the Thompson test to evaluate for an Achilles rupture. Now, we do know that KD had a Achilles rupture, but initially it wasn't that diagnosis, and there can be challenges with any clinical evaluation. It's not to criticize anyone or put blame on anyone for a misdiagnosis. The clinical evaluation is not always clear for many diagnoses, and we're just going to be talking about how to evaluate an Achilles rupture, and then some of the things with a calf strain or injury and the anatomical considerations that can be related to it that may allow you not to have such a clear diagnosis. All right, here we go. So this is a calf of an able-bodied volunteer, and he does not have an Achilles rupture. But what I'm going to do is sort of go over what the simple evaluation is. So in this case, the patient is lying prone, stomach down, and showing the calf. So you see the calf musculature here. Right along here, you see the heel cord. So seeing the heel cord, just visualization of the heel cord tells you that it's unlikely to be a complete disruption. Now, you could have partial tears, you could have bruising, you could have all sorts of things. But the calf musculature extends from medial and laterally. So when you have the muscle itself, it can attach from above the knee and come all the way down through a confluence and form into the Achilles heel cord. And then you can get ruptures here. Now, when I do, it's called a Thompson test. When I do this, you see right here, he has plantar flexion that's involuntary. You see the heel cord being pulled here. Now, if, for example, and then I'm going to mimic it, and basically, if, for example, he had an Achilles tendon, he wouldn't have as prominent a heel cord, and when I do this, there wouldn't be any straightening. Now, obviously, I'm resisting it to create that, and there's plenty of videos out there on what a Thompson test is, so you can look it up yourself. But this is just to understand what a negative Thompson test is. So you've got this, he's got plantar flexion, that's a negative Thompson test. If it didn't move, it's positive. So that's the important thing. Now, when you're evaluating the calf, I mean, you've got the gastroc muscle and the soleus underneath. So there's multiple muscles around the area. So you could have a strain up in the area of the knee. You could have a strain here. You could have ruptures within the muscular area or right at the watershed area, right at the musculotendinous junction, where you often get Achilles ruptures. Now, the neurovascular anatomy and kinematics of the ankle are such that you could have a calf strain or cramping, but a negative heel cord sign and a negative Thompson test. However, most of the times, if you've had a complete disruption, it will be positive, meaning you won't have movement in the ankle when you press on the calf like you do here, okay? And so, again, clinical diagnosis is not always black and white, and I think it's important to understand there's a lot of anatomical considerations, but if you have an Achilles rupture, this is the test you always want to do. Thompson's, and then inspection and palpation of the heel cord. So you can have, sometimes you could have a partial tear, you could have a incomplete tear, and you may have a lot of calf pain. So you palpate the calf and it's just sore and tender, and maybe it's pain-limited dysfunction. But even with that, Thompson's test is pretty specific. I think the specificity and sensitivity of that particular test is very high in the literature. So it's usually the best test to determine that. However, if he didn't have a complete tear before and then it was a calf strain with a partial rupture, it could confuse the clinical picture, and then later he tore it even though it was only partially torn before. or he had a complete tear. Could it have been a misdiagnosis? That I'm certainly not going to say that. I wasn't involved in his care. I did not do his clinical exam and review his imaging. So it's very easy to point blame and say, hey, he missed his Achilles rupture, but not everything is clear, and I think we need to be fair and evaluate what exactly was going on. Other things that could also occur, could he have had, say, a pinched nerve in his back? It could present as calf pain. Could it have been a true calf strain as well as tenderness resulting in limited mobility and function? Did he have a gap? Did he have swelling? There could be a lot of factors that are involved in doing or in having an Achilles rupture and the recovery process and the injury that may be subacute or chronic, and that could cause some overlapping symptoms. Now, usually if you have a absence of the heel cord and a Thompson test, you pretty well have a diagnosis of an Achilles rupture clinically. So some people say you don't even need an ultrasound or an MRI. But ultrasound's pretty easy. Bring it by the bedside, ultrasound directly over the Achilles, you'll know right away whether there's a partial or complete heel cord test. MRI still gold standard, but the ultrasound is getting pretty good. But again, the clinical diagnosis is key. But you can have overlap with a number of different symptoms, and so it's understandable that at some point it was diagnosed as a calf strain, later identified to have a complete Achilles rupture, and it can happen to the best of anyone in terms of misdiagnoses or a diagnosis that came up later that was previously unrecognized because of other symptoms or other pain.